duration and not the erythema. If by any chance you miss the reading or the patient does not report back for the reading, you can repeat the test within 7 days to avoid booster effect. However, if the test has been done in the past, maybe several years ago, and it is more than 10 and increased by 6 millimeters than the previous documented finding, is considered to be positive for a repeat tuberculin skin test. The interpretation of the PPD skin test depends upon the profile of the individual, from the area from where the patient is coming, and multiple factors which we can find on the CDC website. Coming to the quantiferon TB Gold, this is a blood test which measures in vitro the interferon gamma released by the T cells following stimulation by the antigen specific to the MTB. In this, two antigens are used, ESAT6 and CFP10. Two commercially available IGRAs are the quantiferon TB assay and TB spot assay, which are both FDA approved. The newer one is QFT Plus. And of course, the major limitation of these tests is the cost issues. As per the CDC and the WHO, guidelines have been updated from 2019 to 2020 and 2021. And latest is you can use either PPD or IGRA without any preference. Both are recommended only for confirmation if one is positive. However, use of both for routine testing is not recommended. So if you have one positive, you want to test, you can go for the second one to confirm. So 15 years ago, the first study evaluating the use of quantiferon TB Gold in diagnosing TB uveitis concluded that it's only slightly superior to this tuberculin skin test in diagnosing TB uveitis. And this is a review. One can refer to this on the role of interferon gamma release assay in the diagnosis and management of MTB-associated uveitis. Coming to both, either of them, both measure delayed type hypersensitivity reaction, or the type 4 CMI, which involves T lymphocytes once they are activated after exposure to the mycobacteria. Both cannot distinguish between latent and inactive TB. In uveitis, none has been found superior in terms of sensitivity, but quantiferon TB Gold is slightly more specific. Now, if you have both the tests done for your patient, and if TST is positive, IGRA is negative, the interpretation is that probably it may reflect an atypical mycobacterium infection or a BCG vaccination which the patient must have received in the previous 10 years. Coming to the second corroborative investigation, which is very important, is the radiological testing. Now, the conflict is whether to do chest X-ray or CT scan chest. By now, everybody is clear that these patients warrant CT chest, which is contrast enhanced rather than chest X-ray. I'll tell you why. Because in our experience, we found that among all the patients who had a final diagnosis of granulomatous inflammation, whether it was TB or sarcoid, the significant association of positive findings on the chest X-ray was found with only the biopsy-proven sarcoid group, not with the other group where the diagnosis was either based on clinical signs or based on radiological signs. So one has to keep the limitation of positivity on chest X-ray in mind. And we found that in patients with uveitis who were systemically asymptomatic, who did not have any pulmonary complaints, the CT chest helped us to establish the diagnosis of either tuberculosis or sarcoidosis in almost 3/4 of the cases, that is 71% of the cases, using only clinico-radiological criteria, not resorting to biopsies. So the third investigation is PCR. The question is when to do. Rather than what to do, most important is should you do it and when should you do it. We have various PCRs like multi-targeted, the quantitative real-time, gene expert, ultra gene expert, loop amplification method, but they all have different sensitivities and specificities, especially when coming to ocular TB. They don't have very good answers. The availability is limited. You need to have a very good laboratory setup. You need to have expertise from the microbiologist. They involve an invasive nature of ocular sampling. So they are preferred only when you have no clues, when the clinical and the lab profile fails to give you a diagnosis of presumed ocular TB, when you have a treatment failure where you've treated the patient with ATT, but you're not getting response. And of course, you need a good expertise and lab facility. What is the take of COTS on PCR is that the COTS found that PCR was not commonly done for diagnosing intraocular TB, and the positive or negative results did not influence management or treatment outcomes in the real world scenario. So, why is it important to interpret signs and investigations in presumed ocular TB? Because, of course, you're going to manage these patients with antitubercular therapy. And this is now, we have the answers from COTS again, where we have the algorithm and guides for initiating anti-TB therapy purely on the basis of signs and investigations. So let's look at TB choroiditis. These are the minimum parameters for considering ATT with consensus, and you can refer to these in COTS publications. So if you have serpiginous-like choroiditis from anywhere in the world, and if you have one of the immunological tests positive, it is a consensus to start these patients on TB. Similarly, multifocal choroiditis, anywhere in the world, if you have one of the immunological tests positive with a positive radiological test, you consider ATT. Tuberculoma, anywhere in the world with a positive immunological test, or chest X-ray purely from an endemic country, even if you don't have, because many of these patients have a Montux negative. So if you have a chest X-ray or a CT chest, these patients warrant ATT. So this is the Ophthalmology 2021 publication of COTS, the report 1, where these algorithms and the guidelines are provided for different clinical signs of ocular TB. So coming to anterior uveitis, so I'll just show you where the absolute consensus is given. So these green triangles are the ones indicating absolute consensus. The blue stars refer to moderate consensus, and so on. So if you have anterior uveitis, the complete absolute consensus for starting anti-TB therapy is in a patient where the immunological tests are positive along with radiological evidence, and of course with recurrent episodes. Moderate consensus is only for the first episode. For intermediate and pan-uveitis, you have absolute consensus for starting ATT in pan-uveitis when you have these set of immunological tests and radiological tests positive. So you have various permutations and combinations. So these are the algorithms given by the COTS. So coming to retinal vasculitis, there is absolute consensus on patient presenting from endemic region with both immunological and radiological tests. And even if you don't have one IGRA positive, you have Montux positive and radiological test positive, there is a consensus for starting anti-TB therapy in these patients. So this is the second report on the guidelines on the management of tubercular uveitis. So summarizing, it's important, very important to interpret the signs and investigations in various permutations and combinations, because these are the ones which form the diagnostic criteria of presumed ocular TB. And you can access the COTS calculator, which is derived from the COTS consensus data on this link. And this is the publication of the COTS calculator for deciding your line of management depending upon the algorithms. So these are basically, again, on the clinical signs and investigations. So thank you very much for having me talking on this important aspect of uveitis.
That was a wonderful talk, Dr. Rima. Ashay, would you start?
Yes, ma'am. Ma'am, thank you for
Amazing
such a lovely talk. Ma'am, my doubt is to the expert panel as well as you is very basic. I thought I'll start with investigations, but you mentioned the COTS nomenclature and restricted yourself to one part of the pathology, that is TB choroiditis, abscess, and tuberculoma. But in literature, we constantly see TB retinochoroiditis, TB chorioretinitis. Is it really wrong? Because it's already well defined. Vishali ma'am, Rima ma'am, anyone can answer. Because should we restrict to whatever given in COTS, or can we use it interchangeably? Because you clearly told that Eales disease, how it should not be used when it is due to tuberculosis.
So we'll have from Dr. Vishali. Please.
I think it's all about standardization, because we want to speak a common language. As you said, there are lots of things in the literature restricted to few publications. Somebody might call it retinochoroiditis, chorioretinitis. Then there is multifocal choroiditis. Then, you don't even know whether it is serpiginous choroiditis, serpiginous choroidopathy, TB serpiginous choroiditis, multifocal serpiginoid choroidopathy, and then there is serpiginous-like choroiditis. So the aim of the COTS is not a nomenclature paper, is to use a standardized nomenclature, especially when you are talking about the publications, so that all of us are on the same page. It does not have much significance in the routine practice, but it's always a good habit to use the standardized nomenclature, like we use for sun.
One very basic question. There may be some comprehensive ophthalmologists in the audience too. How would you use your various modes of steroid therapy and immunosuppressants, be it chronic anterior uveitis or intermediate or posterior uveitis of this disease entity? Just a very gross.
So I think the interior uveitis, it's primarily topical steroids and ATT only for recurrent cases. First episode, we usually don't start anti-TB therapy. For intermediate uveitis, posterior and pan, patients need oral steroids. And in case it is kind of, showing a recurrence despite the best therapy, of course, under the cover of ATT. So sometimes the response may not be that, maybe suboptimal. So we think of supplementing with intravitreal Ozurdex implant, but one has to be very careful that, it not in the cases of tuberculomas, the other forms of TB, uveitis, choroiditis like serpiginous or multifocal. And generally, these patients respond well to oral steroids. Some of the ones who go on with recalcitrant or relentless progression are the ones who need immunosuppressive therapy.
Ma'am, in the table which you showed about the cards about different tests, ma'am, there was no PCR because only radiograph and the IGRAS were there. So as you mentioned in your presentation, PCRs have different sensitivities. For PCR, it is 33 to 67%, quantitative real time about 57, and the multiplex at 78, and the loop mediated being the highest. So, which is at 86%. Is there any role for PCR in day-to-day practice, or is it the combination of these things will give us a better picture?
No, of course, the role of PCR by COTS, that was it, that it did not really make a difference. And it's not that many experts can have the access of doing a PCR. So the idea of, these terminologies is for presumed ocular TB, where you don't have to resort. But if you have facility and you are seeing these cases which are recurrent, you want to confirm your diagnosis, so one should do PCR.
Yes. That was
May I make a small comment?
Yeah. Yes. Yes.
So regarding Ashray's question, I would probably want the opinion from Dr. Vaishali and other experts. I am under the belief that these terms, multifocal choroiditis and other terms that Ashray mentioned, can be used as a working diagnosis, and it gives you some amount of information about the pattern recognition of a particular finding on fundus. And once you have investigated thoroughly and you label it is topicular or non-topicular, only then you probably use this COTS terminology. So please correct me if I'm wrong. I mean, this is my impression of what I've read so far. So is it the right approach, Dr. Vaishali and Dr. Padma Malini Somashila?
That's true. When you see multifocal choroiditis, you have to bear in mind that there is a classic entity called multifocal choroiditis with panuveitis, which is automatically believed to be autoimmune in nature and responds to immunosuppressive therapy. Now, when you call it multifocal choroiditis, similarly, there is serpiginous choroiditis. When you call it serpiginous choroiditis, by definition, serpiginous choroiditis is an autoimmune disease, which, has the treatment immunosuppression for it. So even if you're finding an etiology to it, you do not use the term which was originally described for non-infectious etiology. So you call it ocular TB. And the same goes for Eales disease. You don't say TB is an etiology of Eales disease because Eales disease, by definition, is an idiopathic disease. And if you have found an etiology, you will call it ocular tuberculosis. You will not say Eales disease. So in a way, you are right that if initially you may call it whatever you want, but if you have ascribed an etiology to it, please don't restrict to the term which was originally described in literature as a autoimmune or a idiopathic disease, because now you have a cause, so shift it to ocular TB.
Right. Thank you very much. We have many speakers, so let's move on. And our next speaker is Dr. Somshila Murthy, again, another very dynamic person, a national and international figure. She's the medical director and head of the Cornea, Cataract, Refractive and Uveitis services at Shantilal Chanvi Eye Institute, Mumbai. And she's going to talk on another very important topic, missing endotheliitis and anterior uveitis. So let's hear from you, Dr. Somshila.
Thank you very much, Dr. Chitra. I feel like old days with the ARC meetings that we used to have. And I didn't realize that I got addicted to them. So I'm feeling very happy to be part of this session. And also my topic may be a little bit not as interesting as Rima's wonderful talk. And that is because mine is, I'm just going to stick to the clinical presentations that we have. And also one important aspect that Dr. Vishali so astutely mentioned, that you may have a terminology, say, as she mentioned, like multifocal choroiditis, multifocal choroiditis with panuveitis, which is ascribed as an idiopathic. But once you have an etiology to it, so then you change its diagnosis to ocular tuberculosis. So this is something like that, where you might have a patient coming in with anterior uveitis, but when you have certain clinical phenotype, actually it is nothing but a viral disease, viral inflammation. And so you change its terminology, you can call it viral anterior uveitis, or you can call it viral endotheliitis, based on which manifestation you see. And sometimes very subtle, but now that we've seen quite a few of these cases, we always start antiviral therapy. So coming to the subject in question, we have viral anterior uveitis as a known entity now for quite some time. In this presentation, I'm going to describe a little bit about the clinical phenotypes. I'm not describing about the common viruses causing this disease. They're listed here in this particular slide. And also I'm going to skip talking really about the debate between PCR guided therapy or clinically guided therapy. Most of the time, most of us who may not have labs or who may not have access to PCR results should go in with clinical guided therapy. And my talk is to help us make a decision on that. So let's dive straight away into the first case. This is a 35-year-old lady and who presented with decreased vision, and she was referred to us as secondary glaucoma, bad secondary glaucoma. Now, the interesting part in her case is that she's having this relentless episodes of uveitis, of inflammation, since the past 16 years. She was investigated multiple times, received therapy as topical steroids, oral steroids, etc. And because of the pattern of raised intraocular pressure with inflammation, she was diagnosed as a Poschler-Schlossman syndrome and was being treated for that. Interestingly, she also had undergone LASIK in both eyes. That is not related to anything to her etiology, but just the clinical manifestation. And she had good vision recovery after LASIK, but after the secondary glaucoma, her vision in the left eye had reduced to counting fingers. So this is the clinical presentation of the patient. What we see here in the affected eye is that there's a very steamy or edematous cornea, and we can see these discrete keratic precipitates. That's what my arrow is showing over here. Some more down here, a few up here. I hope that it is also appreciated. In addition, the patient is pseudophakic. The pupil is sort of fixed and dilated, and there is the rim of the anterior capsule, which is now opacified. The slit is trying to show an interface fluid syndrome that the patient had, not really able to capture it on slit. But on anterior segment OCT, you can see very clearly, this is the anterior surface. There's a fluid interface in between, which is separating the rest of the cornea from the LASIK flap, which was there earlier. And the entire cornea is thickened. And look at how the OCT also picks up those granulomatous keratic precipitates just hanging on the endothelium like this very well. So this is the entry-level pictures that the patient had. Intraocular pressure at this point was 42 millimeters when measured in the periphery. With the interface fluid, the pressures in the center was measuring almost normal, because you know that you'll have fallacious measurement. So in the periphery, it was 42 millimeters of mercury. She had some cells in AC, and unfortunately, in almost 0.9 glaucomatous disc cupping in that eye. So our clinical diagnosis itself was sort of a CMV keratouveitis, or you can call it CMV endothelitis and anterior uveitis with secondary glaucoma. And this was a few years earlier. And since we have access to very good lab, so we asked for, we planned to do a AC tab and send that for real-time quantitative PCR. And we also planned almost simultaneously, as soon as we take the tab, to start the patient on oral Van-Gyn cyclovir, which is the treatment of choice for CMV endothelitis. So we started our Van-Gyn cyclovir as well as topical steroids, and of course all the AGMs, oral and topical. And meanwhile, the real-time PCR results showed that she had very high copy numbers of the virus in her from her aqueous. So we were on the right track. This is a CMV endothelitis, and just a week after starting ganciclovir, you can see how the corneal transparency has recovered. The OCT shows completely resorption of the fluid, and the intraocular pressure has decreased to 28. But because she had such a high copy load, I feel that starting the antiviral therapy worked so well for this patient. But she did need a trab with MMC because of advanced glaucoma, which was still not controlled with maximum medical therapy. And we've been following her up. I also recently saw her a year ago when I was at LVPI last year, and she's doing extremely well in terms of her cornea, intraocular pressure. She took a complete 3-month therapy of Val-Gan cyclovir and did not need further therapy for either for the CMV endothelitis or for her inflammation. Since then, unfortunately, vision doesn't improve beyond 20/100 because of her advanced disc damage in that eye. So this was a case of CMV endothelitis, which was sort of missed for almost 16 years that the patient has been having this disease. And why do I call it endothelitis? Especially CMV amongst the viruses, of course HSV also, just loves the corneal endothelium, attacks that. And in the case of CMV, you can see very early distress of the corneal endothelium. Of course, this patient had the disease for so long. So it's not surprising that this was at entry level. Because of edema, you can't get the scan. And within a 4 months visit, there is the endothelial cell mosaic can be seen a little better. And this is the final visit. Even now, it's same. She has about an endo count of 1369. So the CMV virus actually adversely affects the corneal endothelial cells, causing its death. The second case is a little similar. He's a 61-year-old doctor. There's one big difference in that he's much older, and he had the history since 4 years. He was on treatment with topical steroids and AGM with high pressures recorded elsewhere. The red herring in his case, and our today's series is on red herring. So red herring in his case was he was also HLA-B27 positive and known to have that since 2014, but he barely had any ocular inflammation because of his HLA-B27, only this one. So because of HLA-B27 positivity, he was treated with methotrexate, and they were on the verge of starting biologicals for him because his inflammation would not go down. And of course, he was on anti-glaucoma medications, steroids, etc., etc. So when he presented to us, he was on 3 oral medications in all and 6 topical medications in all for the disease in his one eye. This is his pictures on presentation. So this is diffuse, showing this corneal edema. You can see its haziness inferiorly. And this broad slit shows the kind of keratic precipitates pigmented, just sort of splashed in the central part of the cornea and a few inferior as well. And the picture on this side shows the left eye, which is absolutely fine. We don't think he had any episodes of inflammation in the left eye, despite being HLA-B27 positive. So this patient's vision at entry was 2016 and significant edema, as I said, especially in this area. So when we have patients with endothelial affection as well as raised pressure and recurrent uveitis, to us, the diagnosis is very clear-cut. It has to be a viral inflammation unless by any other means it is proved otherwise. And these patients need antivirals, which is a type of virus we need to either based on clinical clues like this patient, we can consider CMV again. That would be top diagnosis for me, but it can also be HSV. So we can do an AC tab to differentiate between the 2 viruses because the treatment is very different. Again, I love doing ASOCT, and you can see those ketic precipitates. They are not old ones, they're quite fresh actually. That's why you can see them hanging like this, and the DM is sewn into folds. This is a specular microscopy for this patient. This is the right eye, the affected eye, which shows a lowered count. Luckily, he presented a little earlier on, so his cornea will not head towards decompensation, hopefully. And he recently also visited us at the new center where I'm practicing, and he's doing fairly well. Again, when we did his TAP, when he first came to us, he had very high copies of CMV DNA detected, and he improved very, very well with oral valganciclovir. One interesting fact about this patient is that even after 4 years, although his vision is good, pressure is maintained, he still uses prednisolone eye drops once a week, he says, to maintain the inflammation, to keep it under control. And he says he's tried everything else, low dose steroids, and nothing else works. So he's a doctor to boot, so he's on this therapy. This is the initial 1 month pictures. Now, the other few cases I'm going to just show you a couple of pictures just to show the clinical features. So this patient is a 33-year-old, recurrent episodes of redness for the past few years, as well as raised IOP in the left eye. See these discrete pigmented ketic precipitates here and there. Very quiet looking eye, hardly anything. Some ketic precipitates inferiorly as well. And again, you can treat this patient with oral acyclovir to start with, because his pressures were more in the 30s actually. And but we did an AC tap. It was positive for HSV1 DNA. So we started this patient on valganciclovir, and he did improve along with, of course, topical steroids. So this is some of the therapy that you can offer, either acyclovir or val acyclovir. The dose is of course different. These are some of the other clinical manifestations. Sometimes you can have corneal edema or get the keratitis component along with anterior uveitis, and sometimes you can have a conglomeration of ketic precipitates, like you can see here, like this, which are pigmented. Both these cases were HSV, as well as these two cases also were HSV. So you had this old inflammatory evidence on the lens. And here you have a central granulomatous anterior uveitis kind of picture in this patient. So these are some of the clinical pictures that I had to share. And we can, so hopefully I'm in time so that we can go on to discussion.
Yes, again, a very interesting talk, very interesting. And while all your examples were on viral etiologies, when would you actually suspect a fungal etiology for this endotheliitis, Dr. Vaishali?
I think Somshala's excellent talk. And when do I suspect? She showed the beautiful signs. CMV is unilateral, high pressure. You see those coin-like opacities. Sometimes, it can be confused with Fuchs, but a very practical thing is that Fuchs does not have high IOP unless you have done a cataract surgery. Fuchs does not present with high IOP. CMV would. And I do PCRs, but that's not like my life depends on them. I go on specular microscopy, compare the counts with other, and if my cornea people are in good mood, they do confocal, try to find out owl-like inclusions, which are not very common, and I start them on ganciclovir without. I love to do PCRs, but even if I cannot do, I like to do it. I would start them on because it's just a gel treatment, Virson gel, and you can see the pressure coming down, the response, and the count on the specular increasing. So these are the parameters that I use. The herpes she hasn't touched, and I don't think we'll get much into the VZV because those are very typical, more classic. You have more of iris transillumination, which you don't have in CMV. There is more of bilaterality. But if you see the herpes group, then you do require systemic treatment in contrast to CMV. CMV sometimes, just one episode's response to Virson gel. But if there is a recurrence, then of course, as she has shown beautifully, you need to add a course of systemic antiviral. And I was very happy to see, like I also have this pilot who has bilateral CMV, and he just uses one drop in 3 days, 4 days, steroid. It works for him. The day he stops it, it comes back, and he uses Virson gel, titrating his own frequency twice a day, and he's happy.
Yeah.
So there is low grade thing which we do not understand, which defies the logic that how come one drop in 3 days is preventing. But if it is working for the patients, why not? It's all about patients at the end of the day. So they're commonly confused with Fuchs, and many a times confused with Fuchs uveitis, and many a times confused with acute anterior uveitis. That is the problem. So for comprehensive ophthalmologist, if the patient is presenting for the first time with uveitis and high IOP, it is viral uveitis unless proven otherwise. No uveitis presents with high IOP.
Right. One thing is that Konya colleagues are always in a good mood.
Ma'am, I would agree
Non-focal,
to.
I guess, is.
Ma'am, I would want to share this small anecdote. I think 10 years back when I was a fellow, Somshila ma'am tried to show me that undulating surface on state line, which he very nicely illustrated on OCT, but I couldn't appreciate them. But I said, yes, ma'am, I can see. So in case 3 of whatever series you showed, ma'am, you showed those small specks within the cornea. So do you think an intersegment OCT will be better equipped to diagnose an endothelitis? And can you differentiate it between immune stromal keratitis and endothelitis and its impact on treatment?
So the anterior segment OCT will only show us that it'll be you can measure the corneal thickness, and in somebody has a doubt whether it is old keratic precipitates versus acute inflammation. So it's beautiful to document, but you can see all of that clinically. You can see corneal edema. You may not have seen the descemet membrane folds, though you said you told me, but that you can document even better on the OCT. But what is more useful is the confocal, which Dr. Vishali and Dr. Vishali summarized it much better than cornea colleagues about the entire management. So the confocal microscopy can actually show us the distress of the endothelium, and we see that typical pattern of owl's eye appearance. We do see it, we do pick it up on confocal. We have to search, it takes a lot of time, search for that. And that can be found only it's supposed to be pathognomic for CMV endothelitis. And in the other cases, what we would see are swollen up cells or something like that in the case of herpetic herpes simplex more often. Whereas in VZV, sometimes you may not see anything much in the cornea, whereas in the anterior segment, you see a lot, like the iris changes and sometimes a dense inflammation, and you'll just see the keratic precipitates. So somehow the first two, CMV and HSV, have a higher predilection for attacking the endothelial cells first. And VZV, it also does it, but in a later part of the story, I guess, when it's untreated. And also, I should have mentioned this, that also using ganciclovir gel for the milder cases works very well. The 2 examples that I showed, the dramatic ones, were patients who were on long-term, were not, we didn't start anything, and that's why we resorted to starting oral right away. But exactly as Dr. Vishali mentioned, that in the sort of milder cases, first, second, third episode, probably we use the gel and we do get therapeutic response. So we don't always have to give oral treatment. That's what I've learned over the years.
Thank you. Thank you.
Anything else, Ashay, before we go on to our next speaker?
One comment, one question actually of Dr. Somshila. If there's a patient who has a lot of KPs, but there's really no inflammation, you've tried everything, but KPs are lots of KPs dusting the endothelium. Do they themselves harm the cornea? Or do you have to really address them, or can you just leave them because patient is asymptomatic, vision is 6/6? So would you treat just for the sake of the KPs?
So hi Malika, do you mean that the departing KPs, as in the inflammation is over and there's still some?
Yes, they don't go. The inflammation, the KPs are not going for months together, let's say.
Right.
Do you
Right.
really have to chase them, or you can just observe?
So keratic precipitates, when they're clear, when the inflammation is resolved, but the keratic precipitates take a much longer time to fade, especially the pigments in them take a much longer time to be cleared by the aqueous, and they do not harm the endothelium. I have documented these serially. I'm not published, but documenting the endothelial cell count serially. So you'll see that black appearance of the pigments. It will block out those areas, but over a period of time it clears, and the cell mosaic and counts, everything remains good. So just KPs alone, even if with pigments, they just get cleared. It takes a long time sometimes, but they do get cleared without damaging endothelium.
Thanks. Thank you.
Can I ask
Ashray, can
Dr.
I make a point?
Somshila?
Okay, Dr. Jatha, sorry, go ahead.
Sorry, Mudit. Both, as I learned from the talk, excellent talks of Somshila. Both the viruses in the HCSV virus and the CMV can cause endothelitis. And suppose we happen to see the patient dilated and we are missing the transillumination defects and the iridoparesis, which may be accompanying some of these cases. What are the clear-cut differentiating features to help differentiate between a patient who would need valcyclovir versus a patient who would need valganciclovir?
Dr. Vishali has covered a few of these points, as in the patients who have supra high IOPs, 40s, 50s, 60s. So my tendency would be to shift towards CMV as a top diagnosis for these patients. And with CMV disease, you have less. I've never seen CMV endothelitis or CMV anterior with keratitis, like what we have in HSV. So you can have stromal keratitis or an endothelitis, focal endothelitis, or something like that. So if I have any keratitis inflammatory event in the cornea, in the stroma, then it's outright HSV. So it's not CMV. So these two features help in a nutshell. I'm sure there's some more I cannot recall. I have a table, but I can't recall offhand. But these two would be enough. Sometimes both look fairly similar. So to be practical, if you don't have access to PCR, because valcyclovir is cheaper, I would start the patient on valcyclovir. Let's say that it's pressure in the 30s, and obligingly, I don't see any changes on the endothelium. So I'll think of HSV first, start the patient on a good therapeutic trial of valcyclovir or acyclovir. And if that still fails and the patient continues to behave the similar way with pressure being high, then I would conclude that this is probably CMV and then add treatment for that. So that is one more approach.
Yeah, I agree. CMV is unilateral. You generally see low-grade inflammation. IOP is high. There are pigmented KPs. And, if you see the coin-like opacities, that's very, very typical for CMV. But when you look at the herpes, they tend to be bilateral. You will have the transillumination defect and the stromal thickness. Like Somshila said, the moment I see thickening in the stroma, a disciform lesion, KPs concentrated around the corneal edema, few folds going here and there, even if there is no obvious keratitis, that is the thing for herpes for me.
Yes.
Very well said.
Very well
You
summarized.
don't need cornea colleagues, Dr. Vishali.
Yeah. So we go on to our next speaker, Dr. Kalpana Murthy, who heads the Department of Uveitis and Ocular Inflammation at Prabha Eye Clinic and Research Center, Bangalore. She's also the president of the Uveitis Society of India. And she is going to take us a little further and talk on scleritis and its masquerades. On to you, Dr. Kalpana. The first two talks were so interesting, so let's get deeper into it.
Thank you, Dr. Chitra, for this kind invite, and I would lovely to be a part of this interesting CME. So my talk is going to be on scleritis, and along the way, I would just discuss about a few red herrings which we can encounter when we see these patients. So when we talk about scleritis, we are referring to a very rare painful ocular disorder, which is very characterized by severe ocular pain. And if it is not treated properly, it can lead to tissue destruction. Now, scleritis can occur as a result of immune-mediated reactions, and this is the in most of the cases. And in minority of cases, it could be as a result of an infection. When we talk about infection, this could be a very indolent infection or it can be a very aggressive infection. And what is confusing is many times this infection can also be associated with an immunological reaction, making our diagnosis difficult. And this can result in therapeutic delays. And if they're not treated adequately, it can result in poor prognosis. A quick look at the sclera. The sclera is an avascular tissue. It has attachments of the extraocular muscles on its surface, and it is highly supplied by nerves. And that is the reason this is extremely painful. And this is the sclera is continuous with the dural and the arachnoid sheaths of the optic nerve. As a result, when you have scleritis, you have pain on moving your eye. So when I see a patient who is supposedly referred to me as scleritis, there are a few questions which I have to ask myself. Is this scleritis, what I'm seeing? So there are a few characteristic symptoms which cannot be missed. And this is usually associated with redness, and the pain is very typical. There is a radiating pain which usually radiates to the head, jaws, or the ears, and this occurs on movement of the eyeball. And very characteristically, it is there and it is significant enough to awake you from sleep. And if the posterior component, posterior sclera is affected, then you can even have diminution of vision. So when you see a patient suspected to have scleritis, it is important to examine these patients in bright light. There is an unusual blue hue which occurs, and you know this patient has had or is having scleritis. This is a condition which should never be ignored. And many times this is associated with systemic involvement, which needs aggressive therapy. So if it is involving the anterior portion of the eye, then we call it anterior scleritis. And it ranges from diffuse, nodular, and it can be necrotizing, as in these figures. And necrotizing is a very severe form of scleritis. You can see scleromalacia perforans in very rare cases where you don't have significant redness, but then there is a melting of the tissue. This is the blue hue which I was referring to, which is usually seen in resolved scleritis, or if they are on treatment. And you can have posterior involvement, and this is what we call as posterior scleritis. Usually, anterior scleritis is very common. Posterior scleritis occurs in 2 to 12% of the cases. But over a period of time, most of them develop an anterior component, and these can coexist as well. Now, when I see a patient with a red eye like this, there is always a doubt whether it is episcleral inflammation or is it a scleral inflammation. And generally, when you put them on the dilating drops, if it is episcleral, usually they start blanching. And generally, episcleral, you don't have that much of discomfort as what you have with scleritis. This is one such patient with episcleral inflammation who was actually referred to me for starting immunomodulation. But if you see his lid, severe meibomian gland disease he had, and once we treated that, this whole thing settled down by itself. This is another child who actually came with a red eye. And if you see carefully, there is a preseptal swelling. And generally, when you see a preseptal swelling like this, you think of an orbital involvement. And this patient actually had an orbital myocystis sarcosis, which had ruptured. And this had caused adjacent scleral inflammation. This is another lady, young lady who had come with severe pain in her eye and redness. And if you see her eye, there is actually a preseptal swelling. There is also an S-shaped lid, which we are seeing. And these are usually patients with dacroadenitis with adjacent scleral involvement. And generally, just a course of steroids is enough. So, orbital inflammations can also present with secondary scleral inflammation, and these don't require very aggressive therapy as a primary scleritis. Now, history taking is very, very important in a patient with scleritis. A history of trauma, ocular surgery, if the occupation of the patient, whether they are injury prone, this would give us an idea if the type of scleritis which we are seeing is infection. Headache is a very, very important clue, and it is a very understated symptom, actually. So in patients with infection, they have a very, very severe headache, and this is disproportionate to the amount of scleral inflammation which you're seeing. If they have a history of diabetes or immune suppression, again, we are going more and more towards infection. It's important to inquire history of joint issues, any skin diseases, any history of drug intake, any systemic diseases which they have already been diagnosed and then they have developed redness. And these all favor more of an autoimmune etiology. And also it's very important to look at the records, old photographs, because it gives you an idea how the scleritis has been treated, how it has been responding to medications, and whether it is refractory to the current medications which the patient is on. This is some pictures of, this is a patient who had a pterygium removal, and I think excessive cautery was done and it had led to limbal ischemia. So this patient came to me with the scleral melt, and just a limbal graft solved the issue with a course of systemic steroids. This is a patient post-cataract surgery who developed a melt. Now, this is another boy who came with, he had a history of ankylosing spondylitis. He was on etanercept for that. And he's never had an eye involvement before. But the minute we saw this eye, the biologic was changed to adalimumab, and the whole thing settled down. This is another patient who came with a scleral inflammation. Interestingly, when we looked at her records and her old photographs, she had this heliotropic rash, and she was actually diagnosed to have dermatomyositis. So these can be important clues from the history point of view. Now, when you see a patient of scleritis, there are certain signs which we cannot miss. When you see these kind of pus pointing, this abscess-like picture, this kind of necrotizing scleritis or a corneal involvement, infection is very high on our list. Whereas if you see something like this, which is like a diffuse scleritis or a nodular scleritis like this, or a very subtle amount of scleritis with some amount of dry eye or keratoconjunctivitis sicca, it goes more in favor of autoimmune etiology. A quick look at the adnexa can also give you a clue. This is a patient who had just had herpes and had developed nodular scleritis 2 months down the line. And so these are cases which actually require antivirals and oral steroids. This is corneal involvement is a very, very important clue. So this is a patient who came with necrotizing scleritis, and she had these subtle blisters which were there on her forehead. And if you see the cornea, she has this kind of scleros, like a keratitis picture over here. And so this was a patient with actually a viral sclerokeratitis. And unfortunately for her, this was more of a necrotizing variety. This is another patient with Pseudomonas associated scleritis. And if you see carefully, these patients have this kind of corneal involvement, and this occurs as a result of the limbitis. And when you see a pattern like this, where there is a peripheral cornea involved like this, this goes more in favor of an infectious etiology. This is another patient with tuberculosis. He had just come with episcleral inflammation and this kind of sectoral corneal involvement. And once you treat with TB and the steroids, this whole thing scars like this. So when you see, this was also published, when you see this kind of sectoral tongue-shaped inflammatory posterior corneal stromal debris with adjacent scleritis or episcleritis, this goes more in favor of infection. In contrast, if you see peripheral corneal infiltrates like this, there are subtle infiltrates which are along with the scleritis, or thinning of the sclera like this, or a corneal melt, this goes more in favor of autoimmune etiology. And generally, we see these kind of patterns with collagen vascular diseases or systemic vasculitis. And this is very important because this should alert us that the treatment needs to be very aggressive in these cases, because these are usually associated with the CNS or a renal vasculitic component as well. It is important to look at the fundus in all our patients with scleritis. They can have disc edemas, this kind of subretinal deposits. You can have exudative retinal detachments, chorioretinal folds like this, or even something like a granuloma-like presentation. And this is what we see with posterior scleritis. Now, this is another patient who had choroidal...
Doctor, 1 minute more.
Yes. Yeah. And if you see carefully, this patient had a T sign, and this can also occur with viral retinitis. Now, when you see a patient with posterior scleral component, FFA can show the chorioretinal folds, ICG can show the tortuous vessels, and you can see this kind of patchy choroidal filling. You can have thickening of the choroid with the T sign, and MRI can help you in some cases. It is very important to find if this is associated with a systemic disease. So look carefully if there are any deformities And this patient has rheumatoid arthritis, any skin involvement or any cartilage problem. Like for this patient had ANCA-associated vasculitis. This patient had a skin involvement who presented with scleral inflammation. And actually, this is a patient with pemphigus. And if they are not treated aggressively, they land up with this kind of scarring. This is an SLE with posterior scleritis. And this is a patient who just had scleritis. And she was treated with topical steroids, but investigations led to diagnosis of limited scleroderma. Now, this is very important because these patients should not be treated aggressively with oral steroids as they can go into a renal crisis. Sometimes it can be challenging because the clinical signs overlap. For example, this lady who had a phaco-vit done, and she had this pustule. We gave, though the scleral biopsies were negative, this patient continued to have progression. And this was not in the form of pustules, but kind of a flat. So we thought this is an immunological reaction. We added an immunomodulator and even a cyclophosphamide a little later. And this is when she started developing those pustules again, which was treated locally as well as systemically with antibiotics. And this is the result which we achieved after that. So these kind of cases can be challenging. And this is another patient with rheumatoid arthritis with scleral melt. And after 2 doses of IV cyclophosphamide develops a hypopyon. So these are a little challenging cases where there is an infection and an immunological reaction overlap. This is available in literature on the different causes of scleritis. These are the investigations which we generally order in patients with scleritis. Again, always when you're in doubt, just explore and check for infection. PCRs are very useful in these cases. Now, depending on whether it is infection or non-infectious, we treat it accordingly. And in recalcitrant cases, we also treat them with biologics. Now, we always, whenever we are involving in DMARDs or biologics, we tend to use a multidisciplinary approach. For example, this is a patient with Takayasu. The rheumatologist thought that things were under control until this patient developed scleritis. This is another patient with rheumatoid arthritis who was otherwise quite okay systemically, but continued to develop this mild inflammation in the eye and required IV cyclophosphamide. Now, this is the end of my talk. So these are the few masquerades which we need to keep in mind when we see patients with scleritis. So this is a patient with IgG4-related disease who can present like with nodules. This is conjunctival lymphoma. And this is one patient, which is a very rare patient who had scleritis with conjunctival granulomas. And this was excised, and this actually turned out to be Churg-Strauss syndrome. I would like to end my talk with this interesting case. So this is a patient who, she's a doctor who presented to us with redness in both eyes. And she had a history of post-COVID multi-inflammatory syndrome. And at this point of time, all her immunological-based tests were negative for vasculitis or collagen vascular diseases. And the only thing which was positive was a positive quantiferon. She was treated with oral and topical steroids initially. She settled down okay, but this congestion just wouldn't go. As we followed up her, we started seeing, this time we did a HRCT. She had a few lymph nodes and her cervical lymph node was biopsied, which showed chronic granulomatous inflammation. Being a physician, she thought it could be related to TB and she was put herself on ATT. Even then, she started developing these, continued to develop these inflammations. And interestingly, what happened was she was totally otherwise, she had no discomfort except for the redness. And each time she would treat it with topical steroids, it would settle down. And of course, she responded better with Combigam because that there was blanching with of these vessels. So incidentally, she developed a steroid-induced glaucoma. But we lost follow-up for a year. And then she came back to us in 2024 with this kind of a lesion at the limbus. Now, this was a lesion involving the sclera, and this was biopsied. And because this was completely in the sclera, we couldn't remove the entire tissue, but to a certain extent. And this actually turned out to be a histiocytic lesion. So this came out positive for CD68 and S100. So this was a Rosai-Dorfman disease, which was affecting the sclera. And a PET was done, which showed no further active lesions. And currently, she's on oral methotrexate, and things seem to have quietened down a bit. So to conclude, again, it is important for us to differentiate between an infection and an immunological reaction because most of our treatment is based on that. as we are living in a developing world where infections are very common, it is important to take this as a priority and all means to rule out an infection first before treating them aggressively with immunomodulation. I thank you all.
Thank you, Dr. Kalpana. That was a wonderful talk where you covered just the entire possible range of etiologies, infective and non-infective. So because you ended off with a different situation, the last one. So the next thought which comes is, if it's a non-infectious scleritis, when would you actually do a biopsy to rule out a malignancy? Would you wait for such a long period, or lose the patient and they come back, or is there some time when you would do it earlier on?
This patient, actually, the pattern of scleritis was itself unusual. So if you keep looking at her serial photographs, it doesn't look at the, I mean, it doesn't behave like a typical scleritis would, because you started seeing that gelatinous lesion. She didn't have much pain. So biopsy would have been my first, but doctors are supposed to be one of the worst patients, actually. So she refused biopsy initially. So, and that is the reason I think, when the nodule had become a lot more larger and she was having a little ptosis also because of that. That's when she decided to go in and, for a biopsy. And probably that lymph node enlargement, what we saw, was all part of that systemic Rosai-Dorfman disease itself.
Ashley, any question before we go on to the next speaker?
I thought it was an excellent presentation, ma'am. Mudit sir, just want to bring our other expert panel, Mudit sir. Sir, traditionally we have been told that any depot preparations are contraindicated. Even in Madam's slide, she had put a question mark on the subtenon injection. And Thomas Albini has been giving, it's a one isolated paper where he is giving subconjunctival tenon injections in non-infectious recurrent scleritis. What is your view on this modality of treatment?
So a few things. Thanks, Ashraf, for the question. But before I go on to that, the most important thing before you consider any such therapy is rule out an infective cause of scleritis. And two very important things which you have to consider is, one is take a history. A lot of times a history of trauma is something which you should always take. We have had patients who had a history of trauma, were treated as a subretinal abscess initially, but it turned out to be an impacted small wooden foreign body which was causing that necrotizing scleritis in that area. So a history of trauma, number one. Number two, look at the appearance of the scleritis. So if you see multifocality, if you see a pus point, yellowish color lesion, like what Dr. Kalpana ma'am had shown those beautiful images, reddish hue usually is what you see in the immune component mediated scleritis. But if you see a yellowish sort of a hue, a nodular lesion, or if you see multifocal lesions, those are often a clue to an infective pathology. So rule those out before you jump into strong immunosuppression or steroids. That's number one. Number two, I know you are doing a bit of a work on the role of localized steroids in scleritis, and you have shown some great results in one of your papers. But I have, to be honest, never explored the role of subconjunctival or subtenon steroids in any case of scleritis. I do believe that there is one school of thought which says it should work, but somehow I'm slightly apprehensive about using a periocular or a depot steroid in these cases. And maybe I will look more into detail some of the data which you will share and then jump into it. But at this point of time, to be honest, I do not practice using depot steroids or periocular or subconjunctival steroids in these cases. You probably are the best person to answer this question, actually.
Remember.
So I think depot steroids or posterior subtenon steroid in a case of scleritis can be very harmful. I've seen a case where it led to a fungal etiology. The patient was given steroid, posterior subtenon elsewhere for a working diagnosis of scleritis, developed fungal etiology. We did the biopsy, negative, did not respond to steroids. It went into an intraocular. Ultimately, the eye was lost, and ultimately there were corneal infiltrates from where we could demonstrate the septate hyphae. So, if we go back to the history, it was all the subtenon Kennicott which led to this fungal scleral abscess. So one has to be very careful before you inject.
Very relevant. I think we are running short of time, so we have to go on. We go on to our next speaker, Dr. Malika Goyal, again, a very dynamic retina vitreous and uveitis surgeon. She's a senior consultant and heads the department at Apollo Eye Hospital, Apollo Health City, Hyderabad. And she is going to take the whole session to a different direction by talking on decoding neuroretinitis. So on to you, Dr. Malika.
Yeah, good evening, everyone, and thanks, Dr. Chitra, for this opportunity. After listening to those wonderful talks, I'm a little dazed. I'll speak about whatever is my experience with neuroretinitis. To begin with, it is an inflammation primarily of the optic nerve and neural retina. Initially, the focus was on the hard exudates, but then it was Gass who showed that disc edema is the primary pathology and precedes the macular exudates, and hence he suggested the term neuroretinitis. So the earliest sign is optic disc edema, which causes leakage of fluid and lipoprotein from the disc, which migrates into the macula into a star pattern because of the Henle's fiber layer, which is arranged in a radial way. And the star starts forming only after 2 to 3 weeks of the onset of symptoms. Also, fluid from the optic disc is able to go subretinally and cause a serous detachment of the macula. So optic disc edema and macular fluid or a serous detachment are the first signs to be seen. And the exudates come in 10 days to 14 days later. The disc edema and the fluid get absorbed very rapidly in the first 2 weeks. So they may not be there when if the patient is seen later in the course of the disease, but the hard exudates take longer to go. The hard exudates typically start becoming visible when the disc edema is already resolving or resolved. This is one patient who had a peripapillary lesion with a severe disc edema and initially came with 2/60. There were no macular exudates as you see at this point. He was treated with steroids with little benefit. Vision was 2/60. So based on the CT chest, the pulmonologist felt that he could start ATT because everything else was negative. And there was within a month, he had improved to 6/9. And at this point, the disc edema had gone, but now you can see the macular star. And 2 months later, the star has also gone and the disc edema has also resolved and he's still on ATT. This is another lady who came 2 weeks post-fever. At least 50% of these patients are post-fever or some such febrile illness and rash. And based on various investigations and the history, we assumed it was rickettsia. And she was placed on oral steroids with doxycycline with good resolution. You can see the vision was 1/60. And post-treatment, she was 6/24. Again, starts with fluid at the macula and some disc edema. Macular star is coming in after 10 days. And after 3 months, everything has resolved. But there is some atrophy of the fovea and some optic atrophy. So it could be a direct infectious invasion of the nerve or an infection-induced autoimmune response. Microorganisms have generally not been isolated from the ocular specimens, and serological evidence of an infection is usually lacking. So it's either infectious in origin or autoimmune. Infectious in origin, most of the Western reports talk only about cat scratch disease as the cause, Bartonella. But in India, I think it's Mycobacterium tuberculosis, as I showed in one case. Also, rickettsia seems to be very common. Toxoplasma, spirochetes, very important cause, syphilis, Lyme disease, and leptospirosis. It could be fungus or nematodes. And it could be viruses, chiefly herpes group or CMV, but also dengue can cause neuroretinitis. As I said, in the Western literature, it's mostly cat scratch disease, which is acquired by contact of cat saliva in coming in contact with a patient's open wound, which could be a scratch or a bite from the cat itself, and the TB. This cat scratch disease is seen mostly in young, otherwise healthy individuals, and they have this whole host of symptoms. There can be a bite mark and surrounded by a rash, painful lymphadenopathy, fever, and fatigue, etc. And the treatment is with steroids, with or without antibiotics. And the antibiotics are the regular broad spectrum antibiotics, including azithromycin and fluoroquinolones. Typical of spirochetal neuroretinitis could be an associated severe anterior uveitis and meningeal or cerebral involvement. Also, bilaterality is more commonly seen in spirochetal neuroretinitis. It could be autoimmune, chiefly sarcoidosis, SLE, or antiphospholipid antibody syndrome, PAN, and the TINU. This was our patient who, she is also a doctor, 55-year-old. She had a very prolonged severe systemic illness, delay in diagnosis, treated initially for several weeks as infective disease with meningitis, but turned out it was an adult onset Still's disease. So there was a lot of delay in starting steroids. And by the time she came to us, there was a further delay of 4 months because she was unconscious, so she didn't even know she had lost vision. So by the time steroids were started, she already had optic atrophy and foveal atrophy. So this is another important cause for neuroretinitis. It can be classified as infectious, idiopathic when there is no cause found, and idiopathic with recurrence. Idiopathic is a diagnosis of exclusion seen again in healthy young subjects with good prognosis. Steroids do not seem to alter the final visual outcome. It's a self-limited disease. When it is recurrent, macular star may not be evident, and if it is present, as you can see in the picture on the right, it may not be in a star pattern. It may be peripapillary or any other location of the exudates. Obviously, when there is recurrences, there is increasing damage of the optic nerve and poorer prognosis. So longer-term immunosuppression would be required in these patients. Now, this is a recurrent patient. We saw this February. He already had an event in September. So when they develop lipid exudates, it is in the peripapillary location and not in the classical macular star appearance. But the vision was still good, 6/6, and we still treated him only with topical steroids because there was no obvious inflammation. Now, how does neuroretinitis differ from a regular optic neuritis, which is the demyelinating type? Neuroretinitis is not associated with an increased risk of multiple sclerosis. So if we see macular star in a patient with disc edema, that may predict less chances of developing multiple sclerosis, which in our country, however, is not very high. Importantly, also, relative afferent pupillary defect is less prominent in neuroretinitis than in a regular optic neuritis. Now, it can present at all ages, but more commonly in the young people. No gender predilection, usually unilateral, but can be bilateral. Importantly, the vision loss is painless, unlike the regular optic neuritis, which starts with painful vision loss. And the vision at presentation can be very good, 6/6, or it can be just light perception. Color vision defect is common. RAPD may be present. And as mentioned, now important is to look for inflammatory signs so that we can differentiate it from a regular optic neuritis, which will not have vitreous cells, venous sheathing, or a mild anterior uveitis. Similarly, papilledema is unlikely to have inflammatory signs. So this helps to make a diagnosis of neuroretinitis if we can pick up some signs of inflammation. Now, since star appears 2 weeks later, it is important to examine any patient with papillitis or disc edema after 2 weeks because that would change the diagnosis. Sequelae could be optic atrophy and RP atrophic changes, or these may not be there. I mean, there may not be much loss if it's a idiopathic type with good prognosis. History should include pets, bites when the pets, tick bites, history relevant to TB, syphilis, HIV, cough, lymphadenopathy, and exposure to flood water, etc. External examination for herpetic lesions, skin lesions, color vision, vitreous cells, and anterior segment inflammation. Perimetry, classical is secocentral scotomas, though it could also be other types like central scotoma, arcuate, or altitudinal. VEP is expected to be abnormal, but ERG is normal. Investigations should be tailored to the history and findings. ESR is important, as also infections. Basic investigations should be for TB, syphilis, Bartonella, rickettsia, Lyme disease, leptospira, viruses, Toxoplasma, Toxocara, and a basic autoimmune panel covering sarcoidosis, SLE, PAN, and GPA or vaginas. So these are the basic investigations in a case of neuroretinitis. Sometimes you might need to do blood cultures and a brain imaging, CSF analysis, if you're suspecting syphilis, CMV, and other infections involving the brain, or to rule out raised ICT causing bilateral papilledema. Now, if an infectious etiology is suspected but serologies are negative, retesting at 6 weeks for rising IgG titers might give the diagnosis. This is a patient we had, relatively young male, who presented with post-high fever. And he also gave a history of fleeting rash, which used to last only 3 to 4 hours at a particular location and then would shift location of the rash itself. He had been treated elsewhere for 6 weeks. Vitreous biopsy had been done, which was negative. And he had been treated there with high-dose steroids. This had been the picture from previous hospital, where he had been treated with steroids, antivirals, and clindamycin for toxo. So when he came to us, we started him on IV pulse steroids. There was not much improvement. As you can see, vision was slightly improved. So we again focused on the history, and we found that this fleeting rash was little unusual, and on looking up the causes for a rash that might shift in few hours, we found only 3 possibilities. So investigated for these 3, and the only thing positive was a Weil-Felix test, which was strong positive, suggesting rickettsia. So we put him on doxycycline, and within 3 weeks, there was a remarkable change in the picture with resolution, which was not happening previously with all other treatments. Multimodal imaging, fluorescein angiogram shows disc edema. SD or the OCT documents as shown a serous detachment in the beginning, later on resolution with coming in of the hard exudates in the outer plexiform layers. Prognosis in the idiopathic and most cases is good. However, recurrent attacks would adversely affect the optic nerve function. However, in my own experience, there are often cases of severe vision loss and optic atrophy, or at least image distortion, color vision deficits, reduced contrast sensitivity, and rarely reported are macular hole, vein occlusion, artery occlusion, even neovascular glaucoma, or just secondary glaucomas, not neovascular, with corneal decompensation. Prognosis of infectious neuroretinitis is variable and depends on the organism. Herpetic infection has been reported to cause severe necrotizing infection and loss of vision. So treatment of idiopathic may not require any treatment. However, systemic steroids are given and may hasten the recovery without altering the final outcome. In case of recurrences, steroids initially and then long-term immunosuppression, even with azathioprine, which is a mild agent, may prevent recurrences. Infectious neuroretinitis, specific to the infection suspected, but if there is a broad spectrum choice, fluoroquinolones or azithromycin are good enough. In children, sulfamethoxazole, trimethoprim combination, or azithromycin, sorry. When we suspect these Lyme disease, rickettsia, leptospira, doxycycline seems to work better than ciprofloxacin or azithromycin. My personal choice is to use a fluoroquinolone levofloxacin having the best bioavailability, which covers for most organisms while we are still investigating the patient. Levofloxacin, and then later on, as the test results come in, we can change the antibiotic. In immunocompromised, these antibiotics may be required for prolonged periods. Differential diagnosis is for any disease that can cause optic nerve edema, like papilledema, ischemic optic neuropathy, neuritis, compressive lesions, and others. Also, bilateral disc edema with macular star could be from hypertensive retinopathy grade 3 and 4, which can also have a serous detachment of the macula. So blood pressure check should be very important before starting investigations. And raised intracranial pressure with severe papilledema can also cause exudates, but those are generally localized around the optic nerve and not as a macular star, though that could also be there. Posterior scleritis can look very much like neuroretinitis. I've seen some patients, but the only giveaway is very severe pain and headache. They can have disc edema and peripapillary exudates, but OCT and B-scan will show choroidal thickening, choroidal elevation, retroscleral fluid, enlarged optic nerve sign. So these will distinguish it from a neuroretinitis. This patient is a syphilitic posterior scleritis that looked very much like neuroretinitis. On treating for syphilis, the entire headache, pain, everything resolved. Thank you.
Oh, thanks, Malika. That was a very extensive, wonderful talk.
Thank you.
Ashay, I think we can just take one question or a very small question. We have 5 more speakers, and I'm sure all of them are wonderful to be heard.
Yeah, I think the madam has covered everything, nothing
Yes.
left for me to ask. Just a small subacute variant of DUSL. So there, there is a worm involved. So
Yeah.
so it is, unless it manifests with the Garcia sign and other signs, it is very difficult. Any pointers to rule out at presentation where there is no macular star?
Yeah, I think migrating lesions and multiple lesions coming at different times, chorioretinal lesions actually, might give the diagnosis. Then you have to look very carefully for the worm. It's not very clearly visible also. I have not seen it, but even the reports which I have seen, the worm is not even very clear in their images. So, but I think the clue would be repetitive lesions in different areas not responding to regular treatment. And laser for the worm is what is advised.
Thank you, Dr. Malika. We go on to our next speaker, Dr. Alok Sen, who's a medical superintendent and head of Department of Vitreoretina and Uveitis Services at Sadhguru Netra Chikitsalaya, Chitrapur. And he's going to talk to us about ocular syphilis, the great masquerader. On to you, Dr. Alok. We're really happy to have you in our webinar and look forward to learning a lot more today.
Yeah, good evening to all. I hope my slides are visible and I am audible.
Yes.
Thank you, Chitra ma'am, for this opportunity. And thank you for sandwiching me between 4 stalwarts before me and after me. So kind of protecting me from the others. So my topic, the topic given to me was ocular syphilis, the great masquerade. And I think it's very apt because of late we have been seeing a lot of patients coming with ocular syphilis even at our center, which we didn't see about 5 or 6 years before. Slides. So I'll start with my gratitude to Professor Amod Gupta, because without his guidance and motivation, I would not have taken up uveitis as a specialty at Chitrapur. So, and whatever I am, whatever I've learned in uveitis is all because of him. So I'll be presenting 4 cases, all of which have one particular OCT finding, which help us make the diagnosis of ocular syphilis. So this was a 48-year-old male who presented with progressive blurring of vision in both the eyes for 6 months. And he also gave history of night blindness. He was a known case of diabetes. The vision at presentation in both the eyes was 6/9. Anterior segment was quiet. There was mild vitritis. You can see the fundus pictures. Both eyes look essentially normal. So this is the fundus, late phase fundus fluorescein angiogram, which shows the diffuse chorioretinitis and with vasculitis and disc stain. At that point of time, we were screening these patients only with VDRL, and VDRL came out to be negative. The HIV was also negative. So we thought that we were dealing with some idiopathic pan-uveitis sort of, and we started the patient on steroids. And this patient actually worsened on steroids. And when we looked closely to the OCT, and what we saw on OCT was these nodular hyperreflectivity over the retina, which you can see very well on the both the scans. The fundus was by and large normal. So this gave us a clue that we might be dealing with syphilis, and we repeated TPHA and VDRL, with both came positive. We started this patient on IV ceftriaxone, which we routinely give in our center. And you can see that how well the things have resolved and the patient improved symptomatically as well. My second case, this patient who is a 38-year male who presented with this placoid lesion, which was quite extensive in the posterior pole and it was extending beyond the arcades as well. You can see the faint demarcation line as well. And there were some yellow-white subretinal, deep retinal spots which were seen, and there was a focal vasculitis as well. Again, this patient had a negative VDRL, but we did an fundus autofluorescence, and fundus autofluorescence showed these hyper autofluorescent lesions, which were corresponding to those dots on OCTs. And you can see this OCT again showed hyperreflective nodular lesions over the RPE. And so again, this gave us a clue that we might be dealing with syphilis. So this was an acute syphilitic posterior placoid chorioretinitis, and a repeat VDRL and TPHA both were positive, and we treated this patient with intravenous ceftriaxone, and you can see the response. Now, this case actually came from Lucknow. He was referred to us as a case of Azur, and he was he had a very high myopia in the right eye and was amblyopic, and this was the only seeing eye. And he presented with floaters and diminution of vision for 3 days. He was HLA-B27 positive, and if you can see carefully, you'll see those yellow spots which we saw in the previous case as well. In this patient at the fovea, there was some amount of vitritis and snowballs, and again the OCT showed these nodular hyperreflectivity over the RPE with vitritis. So we made a diagnosis of syphilis, and VDRL, TPHA both were positive, and this patient was treated with IV ceftriaxone with good results. My last case is a 30-year-old male who had sudden diminution of vision for 10 days. He was an HIV positive patient who was on ART for 11 years. And he had these ground glass deep retinal lesion in both the eyes and with subretinal yellow precipitates. And again, this patient on OCT showed hyperreflectivity of the outer layers as well as nodular deposits over the RPE. And there was not much of inner retinal involvement. This gave us a clue that this could be syphilis. And we started, both the VDRL and TPHA were positive. We started the patient on IV ceftriaxone and continued with ART. And these are the results after 14 days of treatment. So Treponema pallidum, as you all know, can affect all the layers of the retina and can have a varied clinical manifestation, of which most common is probably retinochoroiditis, and the placoid form is the most typical presentation. Now on OCT, the hallmark is an intact ELM and disrupted ellipsoid zone with granular hyperreflectivity and nodular elevations at the RP. And non-treponema test may be falsely negative in 30% of the cases and can be a red herring. So for screening, one should use both treponemal as well as non-treponemal test. And thank you so much, ma'am. I think I'm on time.
Yes, very good. And everything very well covered. Ashray, just one question, Ashray.
Actually, I think yes, though it's a big spectrum, sir, in treponemal tests, we have different tests, RPR, FTA, ABS, and TPHA. So is it necessary to do all the three, or you would choose one test which you consistently do with the non-treponemal test like VDRL?
So we usually do TPHA. I am sure the others will also do the same. We don't usually do multiple testing. We just stick with VDRL and VDRL titers and TPHA.
So Ashray, just one quick comment. Can I just make one here?
Please, sir. I was expecting you to
So the thing is that if you look at it, FTA ABS is not very easily available in most labs, but TPHA is very easily available. The other point to remember is that TPHA has got a sensitivity of more than 90% for ocular syphilis, as compared to VDRL, which has only got a sensitivity of around 70%. And if you looked at the cases that Dr. Alok had shown, those beautiful images and those cases, 2 of those cases that are VDRL negative. In fact, we also did an analysis of our cases and found that 30% of cases can have a VDRL negative, and therefore the ideal test to look for ocular syphilis should be a TPHA, which is very easily available in most labs. So you use TPHA to diagnose it, and VDRL titers can be used as a clue to resolution of the disease. So the definition of cure for syphilis is a clinical resolution of the lesion, and a fourfold reduction in the titers of VDRL. So use VDRL as a mark for seeing the resolution. But for diagnosis, TPHA works very well and it is very easily available in most labs and is not costly either, just costs around 200 to 350 rupees per test.
I think just one liner for this would be what Mudit said is absolutely correct. Once positive, TPHA is always positive. So one has to keep this in mind.
Yeah.
Thank you very much. We go
One
on
last point,
next.
if I could- just one very quick point, Ashray,
Yes.
is that the treatment of choice ideally is crystalline penicillin, but if it is not available, then ceftriaxone, like what Dr. Alok had shown. If that is also not available, then a good alternative can be oral doxycycline, 100 milligrams BD for 28 days. Even that works. If you've got nothing else available, then you can resort to doxy.
Thank you, sir. Sir,
Thank you.
just a follow-up. Is interstitial keratitis, is it penicillin contraindicated? Sir, you can go ahead and use.
You can still go ahead because usually ocular syphilis is supposed to be treated according to CDC on lice of neurosyphilis.
Okay. Thank you.
So we go on to our next speaker, Dr. Padma Malini, who heads the uvea and ocular immunology services at Narayan Nethralaya. And she's going to talk on rickettsial retinitis. On to you. Thank you for being with us today.
Thank you, ma'am, for the invitation. Very good evening to all of you. I'll be talking to you on rickettsial retinitis. Rickettsiosis is the emerging zoonotic disease. It is caused by the gram-negative intracellular bacilli. The emergence of rickettsial diseases are common from the year of 2000, and it has been distributed all across the India, and scrub typhus is the commonest systemic manifestation. This outbreak are seasonal trend and mostly they present post-rainy season, not only in the systemic, but also in the ocular features we have seen. Yes, rickettsial disease, an underestimated cause of posterior uveitis. Ocular involvement may have been overlooked due to misdiagnosis or self-limiting asymptomatic nature of the disease. The recent years, the cause of symptomatic posterior segment manifestation due to rickettsial infection is increasing due to better recognition of the typical ocular changes. And also, there are increasing number of cases due to globalization and climate change. Coming to rickettsiosis, in the genera, they can be divided into rickettsia or orientia. In the members, there are three groups, that is spotted fever group, typhus group, or orienta group. Coming to the rickettsial infections in India, the typhus or the endemic typhus spread by the rat flea is caused by the rickettsial typhi. Spotted fever group or the Indian tick typhus spread by the tick or rat flea. It's caused by predominantly by the Rickettsia coronae. Scrub typhus spread by the mite. And rickettsial species is Orientia tushkamushki. Coming to the systemic manifestations of rickettsial disease, the incubation period is about 5 to 10 days. The commonest systemic presentation is fever, maculopapular skin rash, joint pains. Typically, we can see tachynoia at the site of tick bite in some set of patients. CNS symptoms and hepatic symptoms can present in certain individuals. As I told you earlier, it is spread by the vectors. It could be the tick is the commonest, but mite, lice, and fleas also can spread the disease. Ocular manifestations can vary from Parinaud's oculoglandular syndrome, non-granulomatous anterior uveitis, and cranial nerve palsies. Now we'll move on to the posterior segment manifestations of the rickettsial retinitis. Commonly, they present in the form of white retinal lesions associated with vitritis, can be associated with retinal hemorrhages and macular edema, or they can have vascular occlusion. This is the first of the case we have reported in 2015 from IJO. In this is the first case we have seen, rickettsial retinitis with arterial occlusion. Recently, we have reported ring-like retinitis could be a feature of rickettsial retinitis in recent observation. Coming to the OCT, we have multifocal retinitis, and they have hyperreflectivity in the inner retinal area corresponding to the areas of the retinitis with aftershadowing, and intraretinal cystic spaces can be present with hyperreflective retinal infiltrates. Fundus fluorescent angiography shows early hypofluorescence with late hyperfluorescence, disc staining, and perivascular staining and leakage, as seen in this case. ACTA is useful, especially the superficial capillary plexus shows extensive capillary rarefaction between the larger vessels with the distortion of the foveal avascular zone, and deep capillary plexus shows poor demarcation of the finer vessels with the loss of FAZ, or brighter areas of projection artifacts are seen in outer retinal layers, whereas in choroid capillaries, we see the change of course architecture with radial striations due to Henle's layer edema, what classically seen in a case of a macular star during the resolution of the Ricketts cell retinitis. Coming to the diagnostic test, Bill-Felix is done from the serum. It is cheap, easily available. However, it has poor reliability and specificity. IgM ELISA is the most sensitive available rapid test, but however, the facilities are available in major hospitals. The next comes immunofluorescence assay. It is a gold standard, most sensitive and specific. It is expansive. It's not readily available at all centers. The next is the indirect immunoperoxidase assay obtained from the serum. It is both sensitive and specific. The molecular assays are also available, such as PCR. It's a rapid test can obtain from the blood. It's available in the reference laboratories. Coming to the interpretation of the Bill-Felix test, this is the commonly we perform when we have OX-K. It is suggestive of a scrub typhus. If we have OX-19, it's present in epidemic or endemic typhus. If both OX2 and OX19 suggestive of a spotted fever or Indian tick typhus. We have significant titers for Indian population if OX-K more than 1:160 is considered positive, whereas OX2 and OX19 more than 1:80 dilution. Classically, in systemic rickettsiosis, a fourfold increase in the two sera within 1 to 2 weeks between the acute and the convalescent phase confirm the systemic disease. Whereas in ocular disease, when we repeated the titer, we found that we also, in contrast to the systemic manifestation, we have seen decreasing titers of rickets cell fever. The clinical resolution of the post-fever retinitis or rickets cell retinitis may proceed with the normalization of Bill-Felix test. Whenever we see a patient with retinitis, we do a clinical examination. We also do a OCT to find the structural involvement. FFA we do whenever we suspected retinal vasculitis. We also have to rule out systemic diseases, and we do investigations to rule out the underlying systemic autoimmune disease or other infective etiologies. If we have specific to fever with skin rashes and retinitis, what classically described as a post-fever retinitis or epidemic retinitis, in this we order specific tests for antibodies for chikungunya, dengue, West Nile, and Bill-Felix test to rule out the cause. Once we diagnose it is a rickets cell retinitis or presumed retinitis, we start the patient on treatment. Coming to a study whether oral antibiotics alone is sufficient or antibiotics for steroids are indicated. In our study, where we have done with macular edema with epidemic retinitis with or without steroids, and we found equal results. There are 2 case reports by Rogan Chawla and Apurva Ayachit where they noticed worsening of retinitis with systemic steroids alone. When they put the patient on doxycycline, they found that improvement in the resolution of the retinitis, and they proposed it is due to infective etiology. If you have retinitis with macular edema, antibiotics alone will be sufficient. If you have retinitis involving the macular area, optic neuritis, or retinal vasculitis, then antibiotics and steroids plays a role in controlling the inflammation. Come to the choice of antibiotic for rickets cell infection, doxycycline, we give 200 mg per day in 2 divided doses for 7 days, or azithromycin 500 mg single dose for 5 days. In children, doxy 4.5 mg per kg body weight. Azithromycin is 10 mg per kg body weight. In pregnant women, azithromycin 500 mg single dose can be given. In addition to that, quinolones also can be used, but they are not effective against Rocky Mountain fever. And the second thing is ceftriaxone also can be used. Let's move on to the case examples. 32-year female, type 1 diabetic, who had decreased vision in both eyes, Will Felix positive for OX2 and OX19, suggestive of tick spotted fever, where we could see the multiple whitish retinal lesions. And she also had macular-papular rashes, which was resolving. And she was treated with doxycycline and systemic steroids. And following 4 weeks, we could see the resolving retinitis in this patient. The next comes as a 28-year male, presented with decrease in vision. Will Felix test again positive for tick spotted fever, where we can see multifocal retinitis with retinal hemorrhages, treated with doxycycline and steroids. Follow-up after 6 weeks, we could see the resolving retinitis in this patient. Case number 3 is a 36-year female, presented with decreased vision. She had retinitis. OCT also confirms hyperreflective after shadowing. When we did the FFA, following sodium fluorescein, she developed artericarial rashes, following which she developed pupillary miosis. FFA was restarted after stabilization of the patient. Through small pupil, we could see the hyperfluorescence in the retinitis lesions in the posterior pole. Following treatment, we could see the resolving retinitis in this case. The case number 4, again, fever with skin rashes. Here, OXK was positive, suggestive of scrub typhus, where classically we can see retinitis with retinal hemorrhages. Here you carefully we can see single yellowish whitish lesions along the inferior arcade in the left eye. OCT shows hyperreflective in the posterior vitreous cavity, intraretinal edema, subretinal exudates. Focal areas of hyperreflectivity shows hyperreflectivity in the inner retinal layer. FFA again shows early hypo with late hyperfluorescence with staining and disc leak. Hyperfluorescence lesions along the inferior arcade of the vessel is seen. Following treatment with doxycycline, we could see the resolution of the retinitis in this patient. Now we'll move on to atypical presentation. Here, 18-year male, this is post-COVID. We started seeing with hypopia, multifocal retinitis with retinal hemorrhages, disc hyperemia, retinal infiltrate with serous detachment was seen. OCT had classical hyperreflective with aftershadowing suggestive of post-fever retinitis. FFA, the patient showed hyperfluorescence with rim of hyperfluorescence, disc hyperfluorescence, and also there was a block fluorescence was seen. Was treated with dogs. Here again, serology came positive for typhus, and the patient was treated with doxycycline and steroids, and we could see the resolving SRF. This is a subretinal precipitate in April. This is May, June, and July. We could see the gradual resolution of the subretinal hyperreflective material in this patient. At follow-up 7 months.
Doctor, 1 minute more.
Yes. Yes. Hyperreflectivity with increasing hyperreflective material. OCTA shows intravitreal anti-VEGF injection we have given for the new vessel complex, following which we could see the resolving subretinal material with intraretinal spaces. FFA shows staining of the CNVM, and following treatment, we could see the scarred vessel complex in this patient. So typically, rickets cell retinitis causes cotton-like lesions, disc edema and macular edema, inner hyperreflective with aftershadowing. Atypical can have hypopia, retinal infiltrate, and new vessel complex can develop. Can I have a minute more?
Sure, ma'am.
Yeah. Can have rickets cell, can it have associated systemic disease association? Here is a patient, 60 years male, presented with decrease in vision. On fundus examination, we could see the typical candleback stripping suggestive of sarcoidosis. But on close look, we could see the focal areas of retinitis. When we investigated the patient, had classical OCT picture suggestive of post-fever retinitis here. And this is a FFA picture showing diffuse perivascular leak with CNP areas and NVE complex. This is the left eye, also showed disc leak and diffuse perivascular leak. When we investigated, the increased serum levels were high, and OX2 and OX19 was positive for rickets cell disease as we suspected focal areas of retinitis in this patient. Chest X-ray showed increased bronchovascular markings. We did treat the patient with doxycycline and steroids, targeted protocoagulation for the CNP areas. Then we put the patient on systemic immunosuppressive therapy. On top of for the left eye inflammation, we put the injection Ocidex as well. So following treatment, we could see the resolution of the lesion. which were published in Ocular Immunology and Inflammation. We also had done tear cytokine analysis. In that, we have noticed increased MMP9 and ICAM, and this was more, and following treatment, it was decreased. In the left eye, we could see during the follow-up, there was slight increase and which responded well to intravitreal Ocidex therapy. This is a OCT showing resolution of the lesions. Points in favor of rickettsia: history of fever, focal retinitis, macular star appearance, and hyperreflectivity with aftershadowing with positive philic test, which made us to suspect rickettsial disease in a classical case of sarcoidosis. Posterior retinitis can occur in pregnancy. Here is a second trimester of pregnancy presenting with retinitis, and we treated this patient with oral azithromycin 500 mg OD, and following which we could see the resolving retinitis in this patient. Coming to the take-home points, rickettsiosis is one of the commonest causes of multifocal retinitis, especially the post-fever retinitis, when a patient presents with fever, skin rash, and retinitis. Indirect immunofluorescence is a gold standard test. However, it is not available, so we resort to Will-Felix test for the diagnosis. Doxycycline is the treatment of choice. It can be given with or without steroids. This is a controversial. The randomized control trial will answer to this clear-cut guideline. And since it's a tick bite infection, prevention is better than cure. I'd like to acknowledge my team members. Thank you for your attention.
Yes, that again was another lovely talk. I think it's one after the other. Excellent talks. If Ashray has a question, we take, because she has been very thorough in all the manifestations. If you don't have a question, we can go on to the next speaker.
Everything is excellently covered, ma'am. There is nothing for me to ask. But just to comment on the immunofluorescent assay, sometimes when it's available, it costs 15,000. So that is again a factor which will go against using it. Otherwise, extremely well illustrated presentation. We can move on to the next presentation.
Thank you.
Thank you very much, Dr. Padmani. We go on to our next speaker, Dr. Kushal Agarwal, who's consultant vitreoretina surgeon, ocular oncologist, and uveitis specialist at Tej Eye Center, Ahmedabad. And he's going to talk on don't miss intraocular lymphomas. On to you.
Thank you, Dr. Ashra and Dr. Chitra, for giving me this opportunity. So today I will be presenting on the primary intraocular lymphoma. My focus on today's talk is on the diagnosis part. So outline is to discuss about various diagnostic signs of vitreoretinal lymphoma and to discuss about vitreous biopsy for such conditions. So I will start with this case. So this case was presented to us for the evaluation of the granulomatous posterior uveitis, and this patient had this kind of subretinal deposits throughout the fundus, and this was the bilateral case. So in this picture I want to focus on this kind of deposits which we see usually in the lymphoma. They are the aggregates of multiple subretinal deposits present throughout the fundus area. So in next few slides, I will discuss about some fundus photos and to pick up on the signs through fundus photos. So this patient was presented also to us with the sign of like uveitis. This patient on the fundus picture, what positive signs we could find was the diffuse infiltration of the optic disc. Moreover, this patient had subretinal deposits. And if we can see, these are the small pinpoint deposits which we could appreciate in the periphery. And in the inferiorly, there were some deposits which were in the scarring phase. So this patient was having the different signs which clinched towards the diagnosis of the lymphoma. I could discuss this case later through pathology also of this case. This is another case which is published in the International Journal of Retina and Vitreous. This patient had different deposits of infiltration in the subretinal layers. So usually lymphoma presents with the subretinal deposits, and there are multiple deposits. This could be a bilateral as well. So from the fundus, we can pick through this kind of pictures. The autofluorescence also helps in the diagnosis. So autofluorescence, usually we see hyperautofluorescence of the active lesions in most of the cases. But in some cases, when there is RP atrophy or when the infiltration is pre-retinal, we can see the hypoautofluorescence as well. So fundus autofluorescence is not like very sensitive test, but we can see some active lesions on fundus autofluorescence. Even in other eye, when there is a no much manifestation of retinal lesions, we could pick them on fundus autofluorescence. So that is also useful tool in the diagnosis. I would briefly talk about the OCT biomarkers. So usually we see irregularity in the outer retinal layers as indicated by the yellow arrows. Moreover, we could see RP elevations and irregularity and sub-RP deposits. So sub-retinal pigment epithelial deposits, this is one of the very characteristic signs of the lymphomatous infiltration. And this infiltration could be sub-RP and could be sub-retinal as well. So here we can see when this scan is passed through these deposits, here we could see that there is a subretinal pigment epithelial deposit. So whenever we see the subretinal pigment epithelial deposits, we should think of lymphoma. Moreover, very rarely lymphoma can present with the pseudohypopion, like dull-looking hypopion. So in any adult patient or middle-aged patient presenting with unusually this dull-looking hypopion, the entry chamber tap should be considered, and lymphoma should be one of the differential diagnosis. So I would like to discuss this case I showed previously. So this patient was a 52-year-old male presented with the blurring of the vision in the right eye for 5 months. Entire uveitis evaluation was unrevealing, and patient was treated with the oral corticosteroid, which were not beneficial. And entry chamber tap for viral PCR was negative. So we could see this infiltration throughout the fundus, and on OCT we could see some vitelliform deposits. So the vitelliform deposits with the lymphoma is not published associated with lymphoma, but our clinical diagnosis was lymphoma. We did a biopsy with the 27 gauge needle through subretinal deposits, and the biopsy turned out to be infiltration of the subretinal space with the lymphomatous cells. This figure A is showing atypical large lymphoid cells with prominent nucleoli. Frequent mitosis were observed, and the tumor cells were positive for CD20 and CD45. So this was the cytopathologically proven lymphoma, and patient was further treated with the methotrexate injection, and ultimately we could see resolution of the lesion, and patient gained good visual acuity. So vitelliform deposits is usually seen in the various conditions as we see in the macular degeneration, but the lymphoma can also be associated with the vitelliform deposit. So this also we should keep in mind as a biomarker. This case we have published recently in the JAMA Ophthalmology. Cytology proven primary vitreoretinal lymphoma in a patient with paraneoplastic cloudy vitelliform submaculopathy. So this is one video in which I want to show now the usual biopsy aspects of the lymphoma. So
vitreous biopsy.
I hope this video is audible. This 2-minute video.
Vitreous biopsy in diagnostic vitrectomy is routinely done in many pathological conditions. But considering small available volume of the vitreous, it is not uncommon to get insufficient and diluted samples. This patient presented to us with diminution of vision, and on examination, grade 2 vitritis along with diffuse sub-RP infiltrates were there. We decided to do vitreous biopsy and diagnostic vitrectomy under air. This video is showing diffuse infiltration of the vitreous along with subretinal pigment epithelium infiltrates. We started doing vitreous biopsy using 3-port 25 gauge pars plana vitrectomy. Assistant nurse was aspirating the biopsy sample through 5 cc syringe attached to the port of the cutter. Herein we see the sample is being taken for the vitreous biopsy, and after taking around 1 cc of sample, air was turned on and the biopsy was continued under air. So herein we see the sample is being taken under air and we can go very close to the lesion and near the retina to take the samples. This could increase the yield of getting a proper diagnosis. Thus, entire diagnostic vitrectomy was completed under air. At the end of surgery, eye was completely filled with the air and the saline was not turned on. The cytopathological result revealed infiltration of the eye with lymphoma cells and patient was treated with intravitreal methotrexate injection and post 7 injection of methotrexate, complete resolution of the lesions were noted.
So in this video, I wanted to show that biopsy could be done under air because undiluted sample could be taken and more amount of the undiluted sample could be taken. And this can be used for doing the battery of tests, and even the sample can be taken very close to the retinal surface as well. So usually for suspicion of lymphoma, I do a biopsy under air. This is a very nice systemic review article published recently regarding diagnostic methods for primary vitreoretinal lymphoma. So they concluded that the interleukin 10 and interleukin 6 ratio greater than 1 from vitreous had highest sensitivity from all of the other tests, and followed by the flow cytometry from the vitreous fluid, followed by the MYD88 gene mutation analysis. So usually we do flow cytometry and IL-10 by IL-6 ratio whenever we do biopsy and see the results and treat patient accordingly. These are my references. Thank you.
Thank you. Thank you very much, Doctor. Now, when you see these cases of primary lymphomas, when do you start doing more extensive examinations like an MRI, CT, or similar tests, or CSF analysis and all that for any extraocular extensions?
Yes, so once we confirm that the patient on biopsy that patient is having vitreoretinal lymphoma, we evaluate every patient with the MRI brain with orbit and the CSF cytology, and we do neurophysician reference. And if anything positive neurologically, then we do combined treatments. So once it is proven on cytology, we do analysis.
Yes, Ashray, any question? Could you ask the expert panel?
Yeah. Ma'am, when you have a fully blown fundus picture like that, it is very easy. I'm not saying it's very, very easy, but it is very obvious to see something is abnormal. But would you give us some pointers like non-response to treatment or any other pointers to even consider this diagnosis? And if there is retinal involvement, and how do you biopsy that if vitreous yield is not there? Anyway, in my map. Okay.
You're asking me?
Yeah,
any of them.
Okay. If it is a patient who is elderly, has vitreitis, and you are looking at the slit lamp, the cell seems larger than WBCs. It's not the usual vitreitis. You are seeing a kind of a sheet, and you do not have synecdoche, or you do not have much anterior segment inflammation. So that will be the first clue that what you are dealing with could be a lymphoma, because the intermediate uveitis typically does not come at that age and with those findings. The second clue, which is that you look at the fundus, and he was showing that it apparently looked normal, but you do autofluorescence, you see this leopard skin appearance. If you have that, again, lymphoma will be first. Third is, it's very important that when you see any subtle lesions, you do OCT through the lesions. If on OCT you see the deposits which are sub-RPE, There is no uveitis which produces sub-RPE deposits other than lymphoma. And if ever you are confused between lymphoma and toxo or other things, you do the OCT through that lesion, you see the rounded roof appearance on OCT of the retinitis lesion. That is another sign that it could possibly be lymphoma. So if you are in doubt, there is no point wasting your time on investigations. Just go ahead with the vitreous biopsy, cytology if you have, otherwise IL-6-10 ratio and mid-88. These are the things,
Thank you, Dr.
Can I
Shaida.
make a comment, ma'am?
Yes.
Yeah. We have done the confocal microscopy. If they have lymphoma cells spread into the anterior chamber, and we have described a floral pattern, either it could be in the form of complete or incomplete particular pattern, that could be one of the imaging biomarker for intraocular lymphoma. In an OCT, in addition to the sub-RP deposits and the round roof, we do get vertical hyperreflective lines. That is one of the early biomarker for lymphoma.
Thank you.
Thank you, madam.
Thank you. We go on to our next speaker, Dr. Mamta Agarwal, who's a senior consultant uvea and cornea services from Shankar Nethralaya, Chennai. And she's going to talk on challenges in sympathetic ophthalmia. On to you, Dr. Mamta. She's there? Dr. Mamta, are you there? Oh. Ashim, maybe you could call her and we could start off with Natasha. She's connected. I would like to introduce Natasha, who's a professor of ophthalmology from Amrita Institute of Medical Science and Research Center, Kochi. And she's going to talk on another interesting topic, common mistakes in uveitis management. On to you, Natasha.
Is my screen visible? Am I audible?
Yes.
Good evening to all. Small change. I've actually resigned from Amrita and I'm at Chaitanya Institute now and visiting consultant at a few other hospitals. But of course, they're very recent, so that's fine. My talk on mistakes in uveitis management can be divided into three parts: mistakes in diagnosis, mistakes in management, and complications due to the management. So where can we go wrong? Some of these mistakes are, of course, made by me, and some of them I've been learning from others' mistakes. So simple mistakes in diagnosis, we'll just go through it quickly. Just that, once we see the evidence of anterior uveitis, sometimes you miss it. The patient comes with pain, redness, photophobia. And even now, even in this day and age, there are people who send off the patient with some drops without doing proper slit lamp examination and missing the keratic precipitates and these cells and flare. So that is a simple mistake that can happen only when the patient comes back with severe redness and pain. Then, actually the patient is put on the slit lamp. The other big thing to do is the failure to see the whole picture. For the example, this patient was being treated as chronic uveitis for quite some time, and nobody has bothered to look at that scleral nodules that were there. Patient was strongly TB positive and ATT, and all of those nodules resolved. The third mistake that often uveitis, once they see the uveitis, the anterior uveitis, they do not do a dilated fundus examination and just treat it as an anterior uveitis. An anterior uveitis is never an anterior uveitis unless you have ruled out that there is no intermediate or posterior involvement. And all the things that we can miss, like a cystoid macular edema, your vitritis, posterior uveitis, a lesion there, or a panuveitis with some vasculitis, all of this can be missed if you do not do the dilated fundus examination, and preferably at the first visit itself. Optic neuritis you can miss, and fundus examination often gives you clues to the etiology. That also you can miss if you do not do it, like the inflammation next to the scar telling you that it is toxo, the tubercles that tell you that you're dealing with TB, the candle wax drippings that tell you that it's probably sarcoid. For example, this patient, 65-year-old man, has been treated as intermediate uveitis with systemic steroids from outside. Worsening was there, and then he came to us. And the typical ARN was there in the periphery, which was completely missed because the person who was treating did not bother to look at the periphery to see those tongue-shaped patches that clearly give away the diagnosis of ARN. And the patient, of course, improved with antiviral therapy. So that is a common mistake, failure to do dilated indirect ophthalmoscopy to look at the periphery. Then, of course, missing masquerade. So especially with children, when they present with something that looks like uveitis, you have to absolutely confirm that it is uveitis itself that you're dealing with and not conditions like retinoblastoma or any other tumor deposits in the anterior segment. Now, going on to mistakes in management, this is a 40-year-old lady who presented to us with decrease in vision, and on examination, multiple sensory neural detachment, mild disc edema, and the FA was fairly typical of VKH with the pinpoint leakages and the bullous sensory neural detachments on OCT. But after we started her on steroids, 2 weeks later, she presented to us with severe ocular inflammation, orbital inflammation, and new lesions that appeared in her fundus, and then turned out to be manto positive strongly, and PCR of the aqueous we did, and it turned out to be TB positive. So failure to do routine investigations, though I think there's a recent publication that say that there is no increased risk of systemic TB when if you are putting the patient on steroids, and you don't have to always do it. But this is our experience that you cannot not rule out TB. And so you have to do your routine investigations before you start systemic immunosuppression or steroids, because in our country, it kind of so ubiquitous, it can coexist with everything. This patient was a 50-year-old lady, pain, redness, and defective vision, presented with exudative retinal detachment that continued to progress in spite of steroids. We had done routine investigations, but then still not responding to immunosuppression or steroids. And more investigations, we realized that she has scleral thinning, and she turned out to be ANCA positive. So you have to think out of the box when you're not having a response, and a rheumatologist and a physician's help is invaluable in the investigations. This patient, a 48-year-old female, she had two pathologies. So she has an adenocarcinoma of the lung, and she's also having TB. That is, let me see. Yeah, she had evidence of TB spine at the same time with bilateral psoas abscess. So here we have two pathologies in the same patient, and the patient presents to us with a large choroidal granuloma-like mass with disc edema and fluid around it. And so we were confused as to, are we dealing with METs or are we dealing with TB? And ultrasound B scan again just did not give us any typical picture. And because finally we decided to take a tissue diagnosis, and a 25-gauge vitrectomy was done, and the patient turned out to be excitone positive for tuberculosis. And just by ATT alone, her lesion reduced and completely flattened and resolved. So when in doubt, a tissue diagnosis can solve many dilemmas. It can be an AC tap, or it can be a vitreous tap, or a vitrectomy and biopsy. Now, another patient, VKH, treated with steroids and azathioprine, developed fever and malaise and turned out to have agranulocytosis secondary to the immunosuppression. So, failure to recognize side effects of the medications that you're giving is also one of the mistakes that we do without proper follow-up of these patients, and seeing the systemic side effects also. And just looking at the eye alone is a mistake that a uveitis specialist cannot afford to do. And this patient was a VKH patient, but completely resolved and was on immunosuppression when they developed a small lesion at the fovea. So here, our FA revealed that it is a CNV. So again, in an inexperienced person, you will think that it is a recurrence of the VKH, but you have to recognize complications that can occur due to the disease itself which is unrelated to the original pathology, and is not a recurrence of the original pathology. And this was CNVM treated with intravitreal anti-VEGFs, and it completely resolved after 3 intravitreal anti-VEGFs. So vigilant for recurrence, recognize complications, recognize new and unrelated disease. This patient is a surprise 32-year-old male presented to us with defective vision and floaters with minimal AC cells. There was a small vasculitis in the temporal periphery, but we couldn't really see anything else. And we sent for the routine investigations, came back 2 days later with pain and redness in that eye. And there was a surprise in the anterior chamber. It was a worm that, when removed, was a gnathostoma spiligerum. And so in uveitis practice, I find that you will, even though you ticked all the boxes, you can still end up getting surprised. So do's and don'ts: confirm you're dealing with anterior uveitis alone. Confirm that posterior segment complications of the anterior uveitis are not there. Simple acute anterior uveitis, you do your basic investigations. Other investigations should be tailored according to the history and findings. Then in your chronic anterior uveitis that needs more than 3 times a day for more than 3 months, you should be giving the patient systemic therapy. Uveitis in children needs thorough workup. Posterior segment complications will need systemic treatment, and don't start systemic steroids in inadequate doses, and don't keep patients on topicals alone if the patient has posterior segment involvement. In conclusion, a thorough and meticulous history taking, complete eye examination, investigating sensibly and ruling out infective pathology, seeking a rheumatology or physician's help when required, and treating adequately and follow closely is your key to a good uveitis outcome. But you should always be prepared to be surprised. Thanking you for this opportunity.
That was again a wonderful talk.
This is all cover in so much time.
No. That was again a very wonderful talk and very nicely completed this amazing session. So I think we have time somehow, due to some reason, speakers could not join in. Ashay, could you take some question?
Ma'am, thank you for this wonderful talk. You also mentioned about the immunosuppression. So after 3 months, it depends on the pathology as well. For VKH, what is your protocol for maintaining immunosuppression? And how long would you keep the patient, and to what level you go, which line of immunosuppression?
I think in every uveitis discourse, we have this discussion as to how long should we keep the patient on immunosuppression. And although the Western world seems to kind of stop it at 6 months, 3 to 6 months is what they say. But I find that in our practice, definitely VKH requires more than 1 year of immunosuppression, most of the time 2 years at least. And I usually start the taper only after 1 year if I find it completely in remission and does not come back at all. And then I keep them on maintenance for the next 6 months and then slowly taper it. Usually about 1.5 to 2 years.
Remember, would you use biologics preferably in any condition, or
we are increasingly moving towards using biologics in pediatric uveitis because we have very good results with adalimumab, and especially if it is started early before the sequelae set in. And so with our pediatric rheumatologists, we have a series of cases that have those who have been started originally on adalimumab itself and those who have been switched over because methotrexate plus MMF and still recurrences are occurring. We are finding very good results. So in pediatric uveitis, I would certainly prefer biologics.
Anything to add, Dr. Rima?
Yeah, so pediatric, sight-threatening, and now the recommendations in the Euler recommendation, Behçet's disease, the combination of azathioprine and cyclosporin is the first line. But now the recommendation is you can start with biologics in very severe sight-threatening Behçet's uveitis as the first-line therapy. Because these are the patients who would need a very long immunosuppression. And as Natasha said, we give immunosuppression for 2 to 3 years for VKH patients and Behçet's patients.
Anything to add, Dr. Jatinder, in all these talks? Some take-home points? Dr.
I
Malik?
just enjoyed the entire show from a balcony seat. It was all the stars performing, and I was just sitting and enjoying thoroughly. I enjoyed all the talks. Thank you, everyone. I just had to share one case of red herrings just to put my contribution in. And this was a case of very classic HLA-B27 related uveitis. and somehow one of our fellows advised for the routine investigation, which I usually don't do. And this patient came out to be VDRL and TPHA positive. So if you are encountering such a case, what would you do? Like, would you also treat syphilis, or would you consider this as a red herring, as what is the title of the session?
What were the eye findings? Only anti-uveitis.
Was HLA-B27 also positive?
HLA-B27 positive, and even MRI was suggestive of ankylosing spondylitis.
So this is infection with autoimmune disease.
One thing to understand here is that we should not get too distracted by one positive test finding. We should continue the complete investigation that is relevant to a case, because this can often happen. You can have 2 or 3 findings, and then you have to see which one fits the diagnosis, clinical diagnosis most, and treat. So,
So it's
But
just
in the
like
presence
adding
of
to
a
what
syphilis,
Natasha, just
sorry, in
adding
the
to what
presence,
Natasha said, that she should be like, we should investigate for TB. After this case, actually, I thought like we should also investigate for syphilis as a routine for all for all
actually,
uveitis.
yeah, I agree. Any case
Not
that we
related
see,
to uveitis though, but it just came positive, and both the things came positive, and patient also gave history of promiscuity later on.
see, whenever we
So
see
can I?
a patient of uveitis, I think it's better to investigate with everything. We need not, with everything, I mean, at least the basic panel, which includes syphilis, HIV, everything. Because, later on, it's too late. We would have spent a lot of valuable time before we reach that diagnosis.
Yeah. So if I can just add, so uniformly for every patient who presents to our uveitis clinic, we do screen them for syphilis. It is such a great masquerade. So as a rule, every single patient of new treatment naive or a new patient of uveitis, every single one of them are definitely screened for syphilis in our clinic. And just one more red herring in uveitis, which can sometimes mimic a lot of these diseases which we discuss, are drug-induced uveitis. So that is another history that we should always take from our patients. What are the specific drugs that the patient is using when they present to us? We have had patients who had presented with angle closure glaucoma and a hypopyon uveitis or bilateral choroidal detachments, treated in lines of uveitis or treated in lines of angle closure, turned out to be topiramate-induced uveitis. So a lot of sometimes, okay, rifabutin, another drug which is used sometimes in TB regimens, is known to cause a hypopyon uveitis. So one specific history which we should always be asking our patients to rule out any of these masquerades is also asking what are the drugs that the patient is using when they present to us, because that in itself can give a huge clue about any underlying pathology, and that will totally change your life management.
Uveitis plus scleritis that presented after zoledronate. Oh, good. Acute orbital and ocular inflammation.
I think we should all be seated at our dinner table, or some people like us have to travel home. So it's been a wonderful, wonderful webinar. I mean, one of those most treasured webinars, the kind of content and quality which came through. So 3 cheers to all of you. Cannot end it in a very conventional way. I think it really needs a big clap. It's been a wonderful learning and so interesting. I think all of us were rapt when the other person was talking. We did not miss out a single point in hearing. Thank you so much for making Eyeedu webinar so memorable. Till we meet again. Good night to all.
Thanks a lot.
Good night.
Thank you, everyone. Bye-bye.
Thank you, ma'am. Thank you so much.
Good night.
Thank you so much.